So we can go ahead and get started. So I'd like to introduce everyone to Dr. Anneli. How do you pronounce your last name?
Savinainen? Yes,
Savinainen.
like it's spelled.
Okay, thanks. Is a Senior Director and Head of Research and Preclinical Development at Aura Biosciences, which is developing a novel treatment for ocular melanoma. She has over 20 years of experience in the pharmaceutical industry in various therapeutic areas and modalities. Anneli received her graduate degree in pharmacology from Northeastern in Boston. Since then, she has held had positions of increasing responsibility in a blend of companies in big pharma and small biotech. Before her current role at Aura Biosciences, she was director of pharmacology and toxicology at Syros Pharmaceutical, where she was responsible for the IND-enabling studies, which led to a successful start of the first-in-human study for Syros oral CDK7 inhibitors to treat various cancers. Prior to that, she was the director of pharmacology at Shire, where she was the non-clinical lead for Shire's ophthalmology portfolio supporting programs from discovery through development up to phase 3. She has several publications in research related to ophthalmology and autoimmunity, and participated and presented her research at multiple conferences. So please, everybody, welcome, and look forward to a good talk. Thank you.
Thank you so much for having me. I'm going to see if I can manage to share my screen without making anything weird. Okay, I'm going to do this too, so I can actually use my pointer. So yes, thank you so much for having me and for the really nice introduction. And as Dr. Fitz said, I'm the head of preclinical at Aura Biosciences, and I'm really happy to be able to show some of the more recent data that we have generated at Aura Biosciences. And the title of my talk today is Ocular Distribution and Efficacy after Suprachoroidal Injection of AU-011, which is a novel treatment for ocular melanoma. So Aura Biosciences is a clinical stage company. We have several clinical trials with AU-011 for choroidal melanoma. This is a very important field because currently there is really no good treatment for choroidal melanoma. The only couple of options are radiotherapy, which usually cause vision loss, or basically taking out your eye, which is obviously not a good option. So this would be a first treatment where we can spare vision loss and spare the eye. So first of all, choroidal melanoma is a rare ocular cancer. Choroidal melanoma is the most common primary cancer of the eye in adults, and it impacts about 11,000 patients worldwide per year. 80% of the patients diagnosed with are early stage disease and treated by ocular oncologists. And similar to cutaneous melanoma, most choroidal melanomas originate in the melanocytic lesions, with a small part being malignant and remaining part being benign. And if you see this eye here, you can see the front of the eye, and here in the choroid, this is where the tumor forms, why it's called choroidal tumor. This is a life-threatening disease, and 50% of the patients will develop fatal metastasis within 10 to 15 years after diagnosis. So Aura Biosciences has a novel technology platform. We have virus-like drug conjugates, or VDCs. These are very similar to antibody drug conjugates, but instead of the antibody, we have the viral-like particle, which you can see here. It is the technology developed by NIH, and it has no genetic material. It self-assembles into this capsid, and it has a very important feature, and that is that it binds specifically to tumor cells. It binds specifically to tumor cells because tumor cells have upregulated modified heparan sulfate proteoglycans, or HSPGs, and that will make the viral-like particle bind to the tumor cells specifically. And to the viral-like particle, we have conjugated a cytotoxic drug, in this case IRDI 700, And that can be activated by laser, by near infrared light. And when it gets activated, it will cause cytotoxicity. On this particle, we have about 200 of the cytotoxic molecules are covalently bind to this viral-like particle. And on the next slide, I'm going to go into a little bit more about the mechanism of action. So in this slide, again, you see that the VDC here, the viral-like particle with the cytotoxic drug conjugated to it, it binds to the tumor cells specifically, which I said in my previous slide, via the HSPGs. And once it binds and we activate this with infrared light, maybe I take a pause here because you might be wondering how we activate this with infrared light. And most of you have probably been to an ophthalmologist at some point, and you know you're sitting there in a chair and they're shining light into your eye. We have modified this by adding a laser where we can basically visualize the tumor, aim on the tumor, and shine the infrared light laser beam onto the tumor specifically, so we don't shine it anywhere else and onto the tumor. It's a laser that is non-thermal, so you won't feel anything. It's just a red light that comes and shines on the tumor. Anyway, when we activate the drug, it will release single oxygens, and that will cause disruption of the membrane and the organelles, which will lead to tumor cell necrosis. So this is the first mechanism. In parallel, when the tumor undergo necrosis, you will see release of damage-associated molecule patterns, or DAMPs, and neoantigens. This will activate antigen-presenting cells, which are going to present those to T cells, which is going to be activated and start proliferating. And they also induce memory T cells. And this is the second mechanism that we have, immune-mediated killing of tumor cells. Now I want to go into just explaining a little bit the difference between intravitreal and suprachoroidal injection. I think most of you have heard about patients getting intravitreal injections, while suprachoroidal injection is still fairly new. It is delivered by a microinjector that Aura Biosciences have in-licensed from Clearside. And if you look at the images here, you can see the difference between intravitreal injection and suprachoroidal injection. So when you do an intravitreal injection, you deliver the drug into the vitreous. And the choroidal melanoma sits here in the choroid behind some of the layers of the retina, which means that the drug is first going to get diluted into the space, and then it has to pass these layers here to reach the tumor. When we use suprachoroidal injection, we actually deliver the drug directly into the suprachoroidal space, which the tumor is. And we do believe that using this kind of administration, we may optimize AU-011's therapeutic index. We currently have both clinical trials, both with intravitreal and suprachoroidal injection. But we do believe that suprachoroidal injection may be the better way to go. And as I said, we do believe we get higher tumor drug exposure this way. We also believe that we get lower vitreous exposure, which may lower risk for vitreous inflammation. And we also can do an optimized treatment paradigm because the drug actually gets to the tumor and binds to the tumor faster than we do when we inject it via the intravitreal route. And to explain the suprachoroidal space, I have this image here. And basically, it's a potential space between the sclera and the choroid that traverse the circumference of the posterior segment of the eye. And this is an attractive site for drug delivery because it enables targeting of the choroid. And in our case, that's where the tumor is. And as I said in my previous slide, this will increase the bioavailability to the tumor and may cause less drug levels in other places. So if you look at this image, it's just illustrating how the suprachoroidal space looks like. So this is the back of the eye, the retina, and you give the injection here, and it's going to spread through the suprachoroidal space, which you can see in orange here. So the first thing we did, now I'm getting into the data, the first thing we did was that we wanted to look at distribution. How does our drug distribute if we give a suprachoroidal injection into the suprachoroidal space? And we did this in New Zealand white rabbits. And in this study, we used a surrogate to AU-011, which is a viral-like particle, but this time it's conjugated with Alexa 488, which has very similar physiochemical characteristics as AU-011, but have better imaging properties. So it lends it better to these kind of rabbit studies where we want to use OCT and fluorescence as imaging technology. And what you can see in these pictures are OCT pictures. These are pictures of the retina. And what you can see is when we give the injection and after about half an hour, it's have started to spread out. You can see this fluid bleb here, which is where the drug spreads out in the retina. And 24 hours after the injection, the retina basically go back to normal and you cannot see this bleb anymore. And using fluorescence, we did evaluate distribution, and when we saw that it is volume dependent, but when we give 100 microliter injection, which is really the normal volume to give both to rabbits and to human, we see a distribution of approximately 70% of the suprachoroidal in the suprachoroidal space, which is very good because if we inject the drug in the quadrant of where the tumor is, we are pretty sure to get the drug to the tumor. The next study, we also wanted to not just look at distribution, but also how long will the drug stay in the suprachoroidal space after suprachoroidal injection. Again, we're using the same model and we're using the 100 microliter injection. And again, we're using our surrogate, the Alexa 488, because it does have better imaging properties. Just so you know, the AU-011 as well as the Alexa 488 is fairly large molecules. They are about 26 kilodalton. So they tend to not be able to go through the small junctions in the eye. So we did believe that it probably stays in this space for quite some time. And when we did the study and we looked all the way out to 21 days, we were able to see that fluorescence were fairly strong through to up to 7 days, and then it starts to fade. So we do believe the drug stays in this space for about at least a week. So as you know, imaging is mostly qualitative evaluation, and we also wanted to look at a more to quantify the exposure, and we did this by developing a bioanalytical assay. And we have this is a study that is also done in rabbits, but this rabbit model, we actually have a model of ocular melanoma where we give human uveal melanoma cells injecting into the rabbit's suprachoroidal space. They develop a tumor, and when the tumor reach an appropriate size, which is about 2 weeks after we implant the tumor cells, we do a PK study again, and we did both suprachoroidal injection and intravitreal injection in this study. And we were evaluating exposure in vitreous and the choroid retina and the tumor itself. And in these graphs down here, after intravitreal injection is the green bars and suprachoroidal injections is the blue bars. So in the vitreous, you can see that we have very high levels of drug in the vitreous up to 48 hours, which was the last time point we looked at, which is not surprising because you are actually injecting the drug into the vitreous. We saw very low levels in the suprachoroidal after suprachoroidal injection in the vitreous, and it's even lower than it looks like in these graphs because these are just 2 single time points in 2 separate animals, and it's likely that because these animals have tumors and that tends to disrupt the Bruch's membrane and the retina, we might have some leakage from the suprachoroidal space into the vitreous in these animal models. When you look at the exposure in the choroid retina, we have high exposures after suprachoroidal injection. It's fairly variable, but that's how it tends to be in these models. And we have lower levels with the intravitreal injection. And then we come to the most important tissue in this study, and that was the tumor tissues. And you can see after suprachoroidal injection we have nice high levels in the tumor, while we have lower levels after intravitreal injection. Keep in mind that we really only need around 1,000 to 2,000 nanograms per mil to see efficacy. So even with the intravitreal injection, we are able to reach exposures that can induce efficacy in this model. But all in all, we do believe that maybe the suprachoroidal route is the way to go. We have less exposure in the vitreous and other ocular tissues, as well as we have about 6 times higher exposure in the tumor, which is the target with the suprachoroidal injection. In the same study, we also wanted to look at distribution, and we did that via immunohistochemistry, and this is distribution in the tumor. I know it might be difficult to see these images, especially if you have small devices looking at, but this image to the left is after intravitreal injection, and this is tumor tissue, and this one is suprachoroidal injection. And I think it's easiest to see the one to the right here. If you see the pink here, it's AU-011, which we stain with immunohistochemistry. And the main takeaway from this part was that AU-011 after intravitreal injection was mostly on the vitreous side of the tumor, while after suprachoroidal injection, it was more homogeneously distributed through the tumor. So this is another point that speaks for the suprachoroidal injection may be better. This is a slide showing the efficacy part of this study, and I explained it a little bit earlier, but basically what we do in these models is rabbit models. We first suppress their immune response with cyclosporin, just to make sure that they won't, make sure that the tumor will grow. We inject uveal melanoma cells, which is a human cell line, into the suprachoroidal space. Then we wait for the tumor to grow. And when it reaches about 5 millimeters in diameter, that's when we start treatment. And the treatment was, in this study, 100 micrograms, and that was administered by suprachoroidal injection, followed by laser activation 16 to 18 hours later. As you may remember, I said in the beginning that the drug binds to the tumor, and it basically binds to the tumor and doesn't come off. So we have a pretty good window on when you can do the laser in these models. We treated once per week for 3 consecutive weeks. After treatment was done, animals were taken down and we did histology of the eye. And what we saw was that untreated animals, as well as extraocular extensions, showed progressive tumor growth. And in the image to the right here, you can see such an extraocular extension, which is tumor actually growing outside the eye. And naturally, a laser activation will not be able to reach this space, so there's no way we have efficacy here, and the tumor is intact. In this space here, you can see some residual intraretinal tumor. And basically, this tumor, we did get exposure because it in that area where in the suprachoroidal space, and we can treat this with the laser, which comes, from the front of the eye and goes through down to here. So in this animal, we saw very good tumor regression after treatment. And overall, we saw about that tumor was eradicated in 80% of the animals after 3 treatments, followed by laser. And we also saw no adverse events in this study. This is just a slide to show a little bit more in detail what you can see in the histology in these animals. And again, this is a control animal. This was only treated with saline. And you can see this big tumor here in the suprachoroidal space. It's a big choroidal tumor. And when you look at these images here is when the eye have been treated with AU-011 plus the laser once a week for 3 weeks on day 1, 8, and 15. And what you can see here is some remnants of tumor. So there has been a tumor here, but it's no longer there because of the treatment. Again, here you can see the tumor is gone. You do see some inflammation in the choroid and some atrophy of the overlying retina. And also you see some, when tumor is gone, you see it's replaced by fibrous tissue and macrophages. So there is a very clear, nice effect in this rabbit model. And of course, we have a clinical trial that is almost complete, and we have seen really nice data with intravitreal injection, and now we have another one ongoing with suprachoroidal injection. So now I just have a couple of slides showing our next indication. And there is a lot of patients with other kinds of cancers that get choroidal metastasis. So this is a most common intraocular malignancy with global incidence of about 22,000 patients per year. The typical presentation here is solitary yellow plateau-shaped lesions with subretinal fluid. They have less pigment than the typical choroidal melanoma. The size is similar, and 66% is diagnosed after primary cancer diagnosis. And where those cancers coming from, the primary cancer is most commonly breast cancer and lung cancer. And then there are others such as gastrointestinal, kidney, skin, and prostate. And then there's a small percentage that is not established where it's coming from. So again, there is a high unmet medical need for these patients to have a vision-preserving targeted therapy. The good thing with choroidal metastasis is we can basically use the same kind of technology and the same dosing regimen because, again, it is a tumor in the choroidal space in the eye. And with our AU-011, we know that it binds to any tumor cell. We have tried many different ones. So we believe that this would be a good treatment for choroidal metastasis in addition to the primary choroidal melanoma patients. And just a few slides to show our early data in this indication. And the first thing we did was to look at in vitro and look at lung cancer cell lines as well as breast cancer cell lines. And we're looking at binding and cytotoxicity here. And what you can see in these graphs here is that we have really nice binding to cancer cells. This is just an example. We are using heparin here, and that is basically blocking the binding sites to HPSG. So that is just to be able to show that they are specific to tumor cells. And once we do the laser activation, we see a nice dose-dependent cell killing here as well. And you can see that for all the cell lines we tested, we have EC50s in the picomolar range. This is the same kind of data, this time in breast cancer cell lines. Again, showing a nice dose-dependent binding as well as a nice dose-dependent cell killing. And again, we have a whole panel of human breast cancer cells, and we have potency in the picomolar range. Here we also tested a couple of mouse cell lines because the next step was to go in vivo and show that we can not just kill these cells in vitro, but we can also kill these tumor cells in vivo, which is my next slide. So here is just one example of a breast cancer model. This is a syngeneic mouse model, the EMT6 model. And it is important for our molecule to have an intact immune system, which is why we're choosing the syngeneic mouse model, because these mice still have a good immune system. So what we see here is that, it's a subcutaneous flank model, so the tumor cells are implanted subcutaneously, and then we wait until the tumor is about 50 to 100 cubic millimeters, and then we do one treatment. So we give AU-011. In these mouse model, we give it as an intravenous injection, and we give 100 micrograms. Then we wait for 12 hours before we do the laser activation, so the drug has time to distribute to the tumor and bind to the tumor cells. And you can see here that the animals that were only treated with vehicle and light, they grow until they reach the human endpoint, while the ones that were treated only once with AU-011 and laser, most of the animals actually have a complete tumor response. There are a couple of animals that have a little bit of tumor growth. And this is also evident if you look at the survival graph here, where the endpoint is basically when the tumor reached 1,000 cubic millimeters. And you can see that none of the animals that got treated with AU-011 reached the 1,000 cubic millimeters, while all the animals in the vehicle-treated group reached the endpoint by day 19. So that was all the data, and the conclusion is that AU-011 has excellent exposure and distribution in the suprachoroidal space and in choroidal tumors after suprachoroidal injection. The data suggests that suprachoroidal administration is superior to intravitreal administration, which may support an optimized therapeutic index for AU-011. We have higher tumor bioavailability with improved tumor exposure and distribution. We also see reduced exposure in the vitreous and other key ocular structures, which may result in an improved safety profile. Initial preclinical data support AU-011 as a therapy for choroidal metastasis in addition to the primary choroidal melanoma. AU-011 shows binding and potent cytotoxicity in cell lines derived from the most common cancer types known to metastasize to the choroid, such as breast and lung. And we have showed robust antitumoral activity in vivo as a single agent using the syngeneic mouse model for breast cancer. I only showed you one, but we have done several of these models, and we also done some studies in lung which show similar results. So I believe that is it from me. I just want to thank all the people that have been involved in this at Aura Biosciences, the CMO Rich Cadmus, and our research scientist Rhonda Kynes has been very important for these studies. Hans Grosnick-Klaus is the one that has developed the ocular melanoma model in rabbit, and he's at the Emory Eye Care Center. And as all pharmaceutical companies, we readily rely on CROs. We have had Covens involved in most of the PK studies that have been done in rabbits, and Stage Bio has been doing our histology and immunohistochemistry. Thank you. That's it for me.
All right. Thanks so much for an outstanding talk. Very interesting. We can wait a minute and see if any questions come in, or otherwise I have a quick question as
Should
well.
Stop sharing.
Stop sharing.
Yeah.
All right, great. Yeah, just had a quick question on the mechanism. I don't know if you can comment anything on the mechanism of photoactivation. That I did a little work on this with attaching kind of drugs to red blood cells back a few years ago. And is it via some type of in chemical biology they talk caging type of mechanism where you cause photodegradation and release of some drug particle or something like that? I just wondered if there was any disclosure or anything into the mechanism.
Any what? Sorry, can you?
If there was any comments you had on the mechanism of photoactivation, or if that was proprietary, So.
Yeah, so it's not completely priority, but because the dye molecule is actually a dye that is developed by Liquor. It's just that the conjugation to the viral-like particle is new, and it's known that it can emit, energy if you activate it. It's used in imaging technologies, just like Alexa 488. But it's novel that once it gets activated and emit this energy, and singlet oxygen is released, it is disrupting the cell membrane.
Very interesting. All right, well, thanks so much. I think we'll move on to the next room. Is that right, Sam?
Sam. And excitingly, the next talk is also ties into hers about preclinical development, so I'll be transferring everyone in just a moment. We'll all be heading over to Dr. Tina's room, and she'll be discussing preclinical development, early considerations.